It's the 4th of February, just general update and some bad but unsurprising news. So I'm on chemotherapy at the moment. You see this pipe that goes into a needle in my chest. Just to show you what the chemotherapy looks like inside. So that kind of balloon has got the chemotherapy agent in. I'm having a chemotherapy agent called 5FU. It has a whole range of nasty side effects, but I'm kind of doing okay with the side effects. Japan is very, very, very good at medicine. It's amazing. It really is amazing. One of the things they're particularly good at, it seems, is dealing with side effects for chemotherapy medicines. It's just fantastic. So, this is, I think, my 10th time or something to have chemotherapy. And I haven't vomited yet at all, which is good. And that's because I'm given the world's best anti-vomit medicine, which is a course of 3 tablets, one you take on the day, one you take the following day, and one you take on the third day, called Emendo. And it's a tablet that targets the bit of your brain that tells your body to be sick. So although I feel sick a lot, well, at least for a few days when I'm having the chemotherapy, kind of feeling sick, I haven't actually vomited, which is, wonderful. That medicine in America costs about $100 a tablet. So $300 for the course. Apparently in America, when the doctor recommends that medicine, your insurance company will usually fight you and say, oh, this is not necessary, here's a cheaper one that doesn't work so well. But because the insurance companies basically don't want to pay for your medical costs, despite that being the whole point of medical insurance. No problems like that in Japan, because Japan is a better country than America. No, it's not. No, it's not. I shouldn't say that. Bad but unsurprising news. I went to see a liver surgeon last week. He said he could do liver surgery, but there's so much cancer in my liver that it wouldn't be what's called curative surgery. Well, I should explain. There was no chance of it being curative surgery in terms of actually curing a cancer, but it wouldn't even be possible to get out enough of all of the cancer in the liver and for it not to return, basically. So when you have cancer tumours in your liver, after liver surgery, there's a big chance of them coming back. And if you have like one small tumour, the surgeon can often take out that tumour and a safety margin around it, and then the surgeon will also, I think, take some biopsies from the rest of the liver and sort of test them to see if there are cancer cells there. In my case, I had 6 tumours in the liver in July, 6 visible tumours, and I don't know, I have no idea how you estimate the invisible tumours, but let's just say for the sake of argument, maybe 20 tumours that are too small to show on a scan. And then of course you have cancer cells that haven't formed tumours. You have lots of cancer cells spread throughout the liver. So although the surgeon could do the surgery, there'd be a very high chance, there'd be 100% chance of the cancer turning to the liver at some point. I was expecting that news. from my very limited knowledge of cancer. That was not a surprise, but anyway, still. And then next week I'm seeing another surgeon at the same hospital as that liver surgeon. And this is a surgeon who specialises in this procedure often called the mother of all surgeries, which is basically the largest. It's like the largest surgical procedure that humans can survive, and can involve taking out bits of sort of 10 organs and some whole organs like your gallbladder, appendix, if you're a woman, ovaries, womb, that kind of thing. So I'm going to talk to him about A, whether I'm even a candidate for this surgery, and B, what kind of outcome I'd get from it. Obviously, a very, very hard question for him to answer, what kind of outcome I'd get from it. It's a surgery that's associated with a lot of death. Used to be a lot of the people who died during the surgery. That's no longer the case. This surgeon said he's never had anyone die during the time he's been here. I don't know how many times he'd done it. That would have to be one of the questions, because basically takes 140 of these surgeries for the surgeon to become competent. And bearing in mind the only kind of surgeons that would even be starting this kind of thing are very, very, very good surgeons, who maybe have a long experience of doing other surgeries, but basically they need to have done it 140 to 170 times to be getting good outcomes. They and their team need to be doing it about 30 times a year, because it's so major. I mean, you're scraping off this double membrane called the peritoneum, which is there to protect the organs. You're removing, hundreds of small, tumours. They basically remove every tumour that they can see, and the surgeon can see tumours that are 2.5 millimetres or bigger. And then during the surgery, you have this thing called HIPEC, where they pump heated chemotherapy fluid around inside the abdomen, and maybe the surgeon even sticks his or her hands in and sloshes it about, tries to get it behind the organs, over the organs, to try and kill the microscopic tumours, these 1 millimetre to 2.5 millimetre tumours that the surgeon can't see, and clusters of cancer cells or whatever. It's very, very, very major. My outcome would probably not be great, because my cancer already spread to the lymph nodes, and of course I've got a lot of cancer in the liver. It used to be if you had cancer in the liver, they just wouldn't consider you as someone that it's even worth doing this surgery for. So that's what I'm going to talk to him about next week. This will be the third time to meet him. So the first time to meet him, I'd sort of just had... So the first time I met him last year, I just had a few rounds of chemo, and he asked me to come back. So I saw him in November, he asked me to come back in December to see how the chemo was doing. And in December, he then asked me to come back next week to... after I'd seen the liver specialist, the liver surgeon. So that's why I'm meeting him again. There is quite a serious problem I have, which is that if he thinks it's worth considering me, he needs to have a look inside me. He needs to cut me open, stick a camera in, and have a look at, well, first of all, can he see any tumours on my organs that have not shown up in the scans? So kind of I know there's cancer in my liver, I know there's cancer in the peritoneum, I know there's cancer in lymph nodes, but it's very likely there's a whole bunch of cancer in other places in my body in that are not showing up on the scans because they're too small at this point in time. And he'll be looking for those, and also he needs to count the visible cancers on the peritoneum. So there's cancers on the peritoneum that they show up on a scan, but only as sort of a bumpy texture because they're below the resolution of the scan. The CT scan or whatever can only see things that are about 1 centimetre or bigger. So he needs to look at those and then calculate a peritoneal carcinoma index. So the peritoneum is divided into 13 sections, and in each section he'll look at what's the biggest size of the tumour in that section, and then there's a score associated with that, and then the total score sort of says A, if it's worth doing the surgery, and B, what kind of outcome you might get. The big issue is my oncologist, so that's the doctor who is giving me the chemotherapy. He doesn't want me to have that procedure at the moment because my current chemotherapy I've only been having for I think 4 months. No, possibly even 3 months, because I've kind of cut things out of the chemotherapy because of side effects, and I've changed the thing called the molecular targeting agent. I had panitumumab, which gave me this crippling skin rash, and I've replaced that with one called Avastin. So the chemotherapist, the oncologist, he really wants to see me having the same treatment for 6 months to see what the result is. So it's really good he expects me to live another 3 months because, I've had I was predicted to live about a year from in kind of August, and I've had quite a lot of that already. So in a way it's great news. He thinks I'm going to live another 3 months, possibly a little bit longer. But yeah, he wants to see what would happen with the chemotherapy. Now, I cannot safely have the surgeon cut me up and stick a camera in me for 1 month after a chemotherapy treatment. I have my chemotherapy every 2 weeks, so I'd have to stop that for a month for 2 times, and I can't start chemotherapy again for a month after having the procedure. So the oncologist doesn't want me to have it until sort of April, May kind of time. So it's a big problem because by then the cancer nurse, let's imagine I am a candidate for this surgery, and there's a possibility of a reasonable outcome. Reasonable outcome means maybe adding an extra year to my life, for example, or an extra 6 months to my life, whatever. But the oncologist, for very, 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 very good reasons, doesn't want me to have it for a while. So I may miss my chance. It's my decision, but in a way, the oncologist is absolutely right. I'll do a part 2 to this video. I'm coming up to the 15-minute mark, and 15 minutes is the limit that YouTube will take for my account. Please donate. Matthew.org, MATTHDWDONS.org if you can. It helps a lot. Thanks.